Good day, everyone. This lecture is part of the surgical diseases of the digestive system. I am your professor for this part of the discussion. My name is Arthur V. Ponce, diplomate of the Philippine Board of Surgery, and I am a general surgery consultant in J.R. Borja General Hospital. Our general objective is to discuss the diagnostic procedures of the GI system, specifically the blood tests, the plain radiography, CT scan and MRI, esophageal manometry, the esophagogram, the upper GI series, the colonogram, and we will also include the esophagogastroduodenoscopy. Patients with GI symptoms should have a symptom-based request for necessary blood workup. As patients who have GI problems tend to have concomitant infections, check for leukocytosis or leukopenia. Patients likely would have bleeding, so check for anemia and the degree of hydration through the hemoglobin hematocrit count. Requests for electrolytes would also be prudent to check for any abnormalities. X-rays are important modalities to consider requesting for diseases of the digestive tract. This will include chest X-ray, abdominal X-ray supine and upright, and cross-table lateral. This is a normal radiograph of the abdomen. This is a radiograph of a patient with small bowel obstruction. As compared with the previous image, the central lucencies are markedly increased in size. This is a chest radiograph of a patient who presented with sudden severe epigastric pain in the ER. Patient is a known smoker with maintenance medications including aspirin. Several bouts of epigastric pain were noted in the past. On examination, the abdomen is rigid. The initial impression is acute abdomen, probably secondary to perforated peptic ulcer disease. On X-ray, as you can see on the arrowheads, we can see lucency on the right diaphragmatic area representing air, which is typically not seen here on normal examination. This is otherwise called a crescent sign or mustache sign, which is pathognomonic of this disease. A computed tomography of the abdomen or CT scan should be part of the routine staging workup for most patients with malignant gastric tumors. Magnetic resonance imaging may also prove clinically useful as a quantitative test for gastric emptying. Arteriography is helpful in poor risk patients with exsanguinating gastric hemorrhage or in the patient with occult gastric bleeding. This is a normal CT scan of a patient. In this image, we can see clearly a protruding exophytic lesion on the stomach, which is a protruding polyp, as you can see on the arrowhead. Next in line is esophageal manometry. This is a test used to measure the function of the lower esophageal sphincter, or the LES, the valve that prevents reflux or backward flow of gastric acid into the esophagus and the muscles of the esophagus. On this examination, a manometry catheter is inserted into the nose. The manometry catheter measures the pressure of the lower esophageal sphincter, and a computer recorder records the LES pressure. And subsequently, the pressure is displayed as a tracing or a graph. Another test we have is the esophagogram, also known as a barium swallow. It is a medical imaging procedure used to examine the upper GI tract, which includes the esophagus and to a lesser extent the stomach. As the patient swallows barium suspension, it coats the esophagus with a thin layer of barium. This allows the hollow structure to be imaged. This is a normal image of the esophagogram. Any deviation from this should raise a concern for the general practitioner. The next examination is the upper GI series. It is a radiographic examination of the upper GI tract. Like the barium swallow, the esophagus, the stomach, the duodenum are made visible on X-ray by a liquid contrast suspension. The next test we have is a colonogram. This can either be a proximal or a distal colonogram. This can be done via X-ray or computed tomography. A water-soluble contrast medium is introduced to gain an image of the colon, as you can see on the image. The last examination we have is esophagogastroduodenoscopy, or commonly known as EGD. A flexible scope is advanced under direct vision in the esophagus, stomach, and duodenum. This is used to rule out cancer with a high degree of accuracy. All patients with gastric ulcer diagnosed should have multiple biopsy taken on the base and the rim of the lesion. These are the alarm symptoms that indicate the need of EGD: weight loss, recurrent vomiting, dysphagia, bleeding, anemia. With the patient on anesthesia and on a lateral decubitus position, the endoscopist inserts the scope to examine the esophagus, the stomach, and the upper duodenum with a small camera or a flexible endoscope which is inserted down to the throat. This is the view through the endoscope. The normal on the left hand side and the view with a peptic ulcer on the right hand side.